Hi everyone, I'm doing a quick YouTube video for you guys just to verbally go over the case studies with you. Feel free, if you feel pretty confident in these areas, you do not have to listen to this video. So I'm going to start off with our hyperthyroid case here. Let me just get this set up. So have yours available. You already should have the answer key that you see in front of you. So, the first thing that you want to do is you see that you have Missy Elliott, who's a 32-year-old African-American female, who's admitted to the hospital with the diagnosis of Graves' disease. Okay, so if you remember from your reading and from your PowerPoints, Graves' disease is a disease that comes pretty hard and causes extreme hyperthyroidism. And it's an autoimmune disease where antibodies are created from your own body. Antibodies are created that stimulate the TSH receptors. Okay? Now, if you stimulate thyroid stimulating hormone receptors, the body thinks that you want to stimulate thyroid hormone, and it starts producing a lot of it. So we know that about her. Is it that surprising that she's 32 years old based on the disease process in your reading? No, right? She kind of fits into that category. Now, this is what she looks like. What do you notice about Missy Elliott? A few things should really jump out at you. One, her eyes. Her eyes are protruding. And actually, if you were doing an assessment on this woman, you would go down to the side, to her lateral side when she was laying back on her back, when she's supine, and you would actually see the eyeball come up and down from a lateral view of it. The second thing you should notice is the huge goiter that she has protruding from her neck and how thick her neck is. This is one where you would see it pretty right away and then have her kind of go back. You would also feel it, okay, but it would stand out to you. So, and I think page 1196 in your textbook is helpful with that. So which of the following is true about Graves' disease? And so when you go back to it, be sure not to confuse it with Hashimoto's disease, which is another autoimmune disease that causes hypothyroidism. Okay? But you do know it's autoimmune, and you know that most of them are unknown etiology. Accounts for 80% of hypothyroid cases. Would Graves' disease result in hypothyroid? No. The disease is mild in nature and does not require treatment. Is that true? No, it's actually a pretty emergent disease. It comes on pretty fast, and we need to do something about it pretty quickly. You listen to Missy Elliott about her recent history. Which of the following events could have precipitated her disease? So take a look at that. A recent UTI and pyelonephritis. So remember, most of the time it's idiopathic, unknown etiology, right? But we do see certain factors trigger this autoimmune disease. And we see that with other autoimmune diseases as well. Recent infection, big one. Smoking, big one. My grandmother and mother had thyroid problems, genetic components, absolutely. My father died last week. Think about that one. Why could that be a correct answer here? So emotional, psychological, mental stress can trigger autoimmune diseases just as easily as a physical infection. Okay? Missy tells you that she doesn't understand what happens with Graves' disease, and you explain the pathophysiology. And I am going to let you guys work on that on your own. You recognize that in Graves' disease, hyperthyroidism and thyrotoxicosis occur together. Is it true or false that hyperthyroidism is hyperactivity of the thyroid gland with sustained increase in synthesis and release of thyroid hormones? So we've talked about it a few times, and it's definitely true. Thyrotoxicosis refers to the physiological effects or clinical syndrome of hypermetabolism that results from excess circulating levels of, and if you remember in your patho PowerPoint and in your readings, they talk about two thyroid hormones, T3 and T4. Now, which one of those is 90% of the circulating hormone? The answer is T4. So if we had to pick one of these, T4 would be the best. Okay, so if you see a question that asks you to pick two things, if you had a question that asked you to pick between T3 and T4, which is going to give you the best indication of thyroid hormone levels, T4 is going to be the best. So you recognize that, and this is a mistake, it should say not two classical clinical manifestations, but what are all of the clinical manifestations of this disease that you could see? What would you expect to see? So exophthalmos, right, on inspection, that's going to be the protruding eyeballs again. And remember, that puts them at a very high risk for blindness, and it's not always reversible. Depends on just how quickly they get treatment. Goiter on inspection and palpation. Okay, we expect that. Do we expect to see intolerance to cold with a hyperthyroid? No, remember that we're talking about a heightened metabolism. Hyperthyroid means hypermetabolism in your body. If your body's overworking, it's going to be really hot. Okay, intolerance to cold is going to be a manifestation of hypothyroidism. So not only does your heart start racing, you get heart palpitations, your speech even gets faster with hyperthyroidism. So that's that rapid speech. Do you think that your appetite would be increased or decreased with hyperthyroidism? Increased metabolism, burning up everything, you're going to have an increased appetite. You would see the decreased appetite with your hypothyroidism because they're not metabolizing things very well, and they also feel full all the time. Okay, so you'll see that as the opposite. What nursing actions should be included in the plan of care for this patient? So let's take a look at all of them. If you apply an eye patch, is that going to protect the patient with the exophthalmos? No, it's not going to stop their eye from drying out. It's not going to prevent ulcers from forming. It's not going to prevent blindness because that's not the issue. It's not irritation to the cornea. It's the inability to close the eyelids and the drying out of the entire tissue. Placing cold packs on the eyes to relieve pain and swelling. So no, we don't do that. And that's also not going to be the best choice. Elevate the head of the patient's bed to reduce periorbital fluid. So you like that one. So let's go to the next. Teach the patient to blink every few seconds to lubricate the cornea. Is that going to be beneficial to your patient? No, because she can't blink all the way. Her eyelids cannot close all the way. So you're left with one best answer. Doing your nursing intervention of keeping the head of the bed elevated to reduce periorbital fluid. Remember, when you have swelling of any extremity, you always want to go with gravity and make sure that you can bring the pressure down. So if you have, for example, intracranial pressure, so in your head, you want to be very careful in what position that you have them in to reduce the pressure. And the same thing with the periorbital pressure, periorbital fluid. Okay, your patient is getting ready to get discharged soon. What information should you include when teaching your patient about Graves' disease? So avoid exercise to avoid increasing the metabolic rate. So that's an interesting one to think about, but we actually don't tell patients that they have to avoid exercise because it's not going to make that much of an impact, and it's not going to actually really change the process that's going on. Surgical removal of thyroid is the only treatment. And you guys have learned of another way, which is you also, yes, you can surgically remove the thyroid. You can also use radiation to kill off some of the thyroid as well. Restriction of iodine intake is needed to reduce thyroid activity. Okay, and that's just not true. Okay, antithyroid medications may take several weeks to have an effect. Yes, that is a really important educational component because a lot of patients think they're going to feel better right away, and they're not. Most of the time, unless it's a psychological placebo effect, they're not going to feel better for a few weeks. It's important for us to warn them of that so that they can mentally prepare because they feel terrible sometimes with this disease. Symptoms of hypothyroidism may occur if you start taking radioactive iodine therapy. So these people have only been exposed to hyperthyroidism symptoms, and now you give them this radioactive iodine, which starts killing off your thyroid. And now too much of the thyroid has been killed off, and you have a hypothyroid situation. And the patient starts feeling cold and slow and sluggish and having constipation and all those things, slow heart rate. So unless you tell them that that's very possible and very common, they may not know to look out for it, and they may think the medication has side effects or it's not working or it's making them worse. So you have to tell them to expect the possibility of that and make sure that they tell their healthcare provider if they have those symptoms. The last one is just plain false. You're not going to have relief in a week from hyperthyroidism. Okay, the two primary lab findings are which of the following? Okay, so here's an example where you have to pick just two of these. So where does your mind go with this? So the free T4, okay, so that's the free circulating thyroid hormone. Remember, T4 is going to be your best between T3 and T4, but they're both good. Okay, so you got that one. Now, why is it decreased thyroid stimulating hormone? Why are we going to see a decrease in thyroid stimulating hormone and an elevated free T4? So we're talking about Graves' disease, right? Now remember, what happens in Graves' disease? You have that thyroid gland, remember your bow tie, right? And it has these little receptors, so create your receptors. Those receptors on the thyroid gland normally accept TSH, okay? However, in Graves' disease, the antibodies that are created fit into those little receptors and tell the thyroid to spew out extra T3 and T4. It's not the TSH fitting in those receptors, it's those antibodies that are formed from an autoimmune disease. The TSH levels are actually going to be very low because your body has that negative feedback loop. So your body detects that you have high T3 and T4, and the TSH is actually going to be very low. However, the antibodies are still going in and stimulating T3 and T4. So that's why those two are the correct answers. And increased TSH is not what we would see in Graves' disease. Okay. Missy needs to take an RAIU test to differentiate Graves' disease from other forms of thyroiditis. What is this test? And actually, it's pretty interesting, but it's right in your book, so I'm going to let you take a look at it in your med-surg book. They have a good little description in there. But it's one way that we can kind of, we can see an uptake and start to differentiate. So I'll let you take a look at that on your own. So Missy comes back to you a few months later. You notice her goiter has increased in size, and she tells you that she's been unresponsive to antithyroid therapy. She's going to be receiving a thyroidectomy. So remember, whenever you have an ectomy, something is being removed, okay? An ectomy. Different from an ostomy, of course. An ectomy is going to be removal. So part of her thyroid is going to be removed. While assessing the patient who has just arrived in the post-anesthesia recovery unit, which is the PACU, and you will hear us say PACU sometimes in the hospital. That's what it stands for, post-anesthesia recovery. After a thyroidectomy, the nurse obtains should be this data. Which information is most important to communicate to the surgeon? The patient is sleepy and hard to arouse. So that actually is pretty normal when you come out of anesthesia, okay? We expect that. But do we monitor to make sure they come out of that? Of course. So the patient has increasing swelling of the neck, okay? They just had surgery on their thyroid, right? So this is quite possible that this can happen. So we like that one, so we'll log that away. The patient is complaining of 7 out of 10 incisional pain from where the cuts are, okay? Is that normal when you come out of a surgery and the anesthesia is, coming off and you're in recovery? Yes, the pain can be pretty bad. The patient's cardiac monitor shows a heart rate of 112. So remember, this person came from Graves' disease, in which your heart rate is very, very fast, and normal heart rate, can go up to 100. 112 is actually not uncommon when they get out of surgery if they were already a little on the higher side, and it's also not that much above the normal. But when you're looking at all of these, even if you had a few that you liked, you have to go back to prioritizing the questions saying what is the most important to communicate. Okay, that's saying what's the most emergent thing? What's the first thing that's going to block airway, breathing, circulation, right? So an increasing swelling of the neck very easily could cut off their airway. So that needs to be communicated immediately. What kinds of things could be happening? You could have blood, a huge amount of blood forming in there, getting stuck. You could have the inflammatory process kind of kicking in a little too hard and swelling in that way. But whatever the cause is, we're worried about their airway. And that can swell up very, very fast and cut off very, very fast. So you need to you need to tell the surgeon that, okay? And there's a video here that I'd like you to watch. Okay, so that kind of concludes that one. Now let's go into the next one here, hypothyroidism. So this is a great video, and I do expect you guys to watch the videos that are included. They do have information that I don't go over with you guys. So this is actually a patient who mentions every single possible symptom of hypothyroidism. She's young. She's just a wonderful example. So, what is the best laboratory diagnostic testing for hypothyroidism? Select the 2 most relevant tests. Now remember, in the previous one we talked about T3 versus T4, and the free T4 is going to be your best, and then the TSH, of course, because you need both in order to figure out who's doing what. So the TSH tells you who's responding. The pituitary, right? The pituitary is the one that spits out TSH. Who spits out the free T4? or T4. Don't let the free part confuse you. Just assume free or not free, T4, T3. Don't worry about the free part. Okay, the thyroid spits that out. So two different areas of the body are spitting out two different things. Okay, and we need the information on both to figure out who's working and who's not working appropriately. So your patient is prescribed levothyroxine, or Synthroid is the more generic name, trade name. Which assessment is most important for the RN to make during initiation of thyroid replacement? So there's a good little drug alert in your book on page 1203, okay, as listed down here, that I want you to read that explains why this is. But basically, levothyroxine can cause angina, dysrhythmias, and can increase myocardial oxygen demand. So make sure you read about that, and then you'll realize why apical pulse rate is going to be your best bet here. Okay. What would be a reason for you to hold the medication and contact the healthcare provider? So this one's a little tricky, I think. So you're giving them, what are you giving them? You're giving them thyroxine. You're basically giving them T4, okay? You're giving them these thyroid hormones, the ones that they were missing, right? Because they were hypothyroidism. Okay. But why? What could you possibly see that's going to tell you, oh, don't give this. Let's consult with the physician and find out if they want to give this anymore, okay? So blood pressure, 102/62. So that looks okay, right? So you're not really concerned about that one. Okay. Elevated thyroid stimulating hormone. Okay. Do you expect that to be a little elevated because they are there's a negative feedback loop? So yes, you could expect that, okay? Distant, difficult to hear heart sounds. Okay, you could expect to have that with a hypothyroid. And also it doesn't really relate directly to our issue. So increased thyroxine or increased T4, why would that be a reason for you to hold the medication? So the whole reason that we're giving them levothyroxine is to bring their thyroid levels up to normal, right? Because they're too low. If you see that their thyroxine levels are now above normal, which I realize this question should say high thyroxine levels. So I don't mean increased as in slightly increased. I mean now they're above normal. So that's kind of needs to be rewritten. But anyway, the point is if you have a patient that has a T4 level that's high now, you are not going to want to give them more thyroid hormone. For the same reason that hyperthyroidism is dangerous, you would be causing that by giving them an extra dose if their thyroid level is already too high. So that's really the point here, okay? Okay, the rounding physician stops by to see your patient. He knows you're in nursing school and asks you a question. Serum TSH levels help determine the cause of hypothyroidism. Where is the defect if the TSH levels are high? What if the TSH levels are low? Okay. So this one is also a little tough for you. It's a lot of thinking. You kind of have to draw out the hypothalamus, draw out the pituitary, and then draw out the thyroid gland, and draw and label who's spewing out which substances, which hormones. Okay. So if the TSH levels are high, okay, so TSH levels are high, but the thyroid hormones are still too low, what does that mean? That means the thyroid gland itself is not responding, right? The TSH is coming, it's being sent out appropriately by the pituitary gland, but the thyroid is not responding. So we know that the problem is in the thyroid gland itself. Now, if the TSH levels are low and the thyroid hormone levels are low, then we know there's something wrong with that negative feedback loop, right? And we know there's something wrong perhaps with the pituitary or the hypothalamus, because those are the ones that are supposed to detect low levels and then say, hey, let's spew out some extra TSH to make up for this. So if you don't see that response in the TSH levels, then we know there's an issue higher up in the hypothalamus or pituitary, something with that negative feedback loop. So iodine is the most common cause of iodine deficiency is the most common cause of hypothyroidism in the world. That's actually why we use iodized salt across America. It's to prevent people from having this problem, which is still very, very prevalent in third world countries. There was a student last semester who actually, her mom always sent iodized salt back to their homeland in Vietnam because they all had hypothyroidism, and they were all deficient of iodine. So that was the one thing they wanted from America. So let's look at this lady, and I know that you probably recognize this. So your patient returns in 6 months with severe myxedema. How would you describe her appearance? So think about this was your patient and you had to document her appearance. What would you say? Okay, you definitely see swelling, right? Swelling, and there's facial swelling, there's periorbital edema. This is also called a mask-like effect. And this is that mixed edema we talked about. That's very classic hypothyroid, right? Your patient tells you she has gained rapid weight over the last year. What would be the most appropriate nursing diagnosis for her? So think about why people with hypothyroidism gain weight. Are they having diarrhea? No, right? Hypothyroidism people, they have constipation. Diarrhea can go with hyperthyroidism. Okay, let's look at some of the others. Disturbed body image related to hypermetabolism. So disturbed body image, does this person probably have that? Yeah, a lot of times they do. Is that related to a hypermetabolism? No, right? It's a hypo. And then the last example is imbalanced nutrition, more than body requirements related to calorie intake in excess of metabolic rate. So that kind of fits your story perfectly, right? Their metabolic rate is not normal. It's actually decreased, and they're taking in more than their body can metabolize, and they're just going to keep adding lipid storage, right? So finally, what should you teach your patient prior to discharge for management of hypothyroidism? Gradually increase your exercise and add fiber to your diet, as well as stool softeners if you are having constipation. Remember how uncomfortable constipation can be. For those of you who have experienced constipation, you remember it makes your stomach hurt, puts you in a really bad mood. You just, everything about your body feels bad when you have constipation. And so that's one of the worst symptoms for these guys in hypothyroidism. So gradually increase your exercise, meaning don't just start running 5-10 miles, because people do that and then they get hurt. So you have to be really clear. Make sure you stay in a cold environment since you have intolerance to heat. Well, you actually have intolerance to cold, so that's not going to be the right answer. Contact your doctor immediately if you have rapid pulse, palpitations, dyspnea, orthopnea, nervousness, or insomnia while taking thyroid hormone replacement. So, what is that warning your patient about with your levothyroxine replacement? It's saying, hey, it's possible your thyroid levels can go up too high, right? Just like the same reason you would hold the medication if you saw high T4. If they start having these symptoms, you're starting to worry that they're becoming hyperthyroidism. And we'll have to decrease their dose probably. Take your thyroid hormone replacement anytime you want during the day. Okay, no, you want to take it at the same time. Again, it's a hormone. And so if you took, a dose at 5 p.m. at night and the next day you took it at 8 a.m. in the morning, you're going to be too high. So you need to take it at the same time so that it's very easy on your body, just like keeps it at a steady rate, steady amount. And then finally, thyroid replacement therapy is a lifelong therapy. So yes, it is. Especially, this is especially hard for patients when they get treated for Graves' disease and they get a whole bunch of their thyroid removed or killed off. Then it's really hard for them to understand that they're going to have to take thyroid replacement therapy usually for the rest of their life. But we do have to warn them of that. Okay, and then the last thing that I wanted to go over really quickly is this last tiny couple questions here. Okay. So which information when obtained by the nurse is most important most important to communicate rapidly to the healthcare provider? So this case study actually is about SIADH. Okay. So again, this is inappropriate antidiuretic hormone. Okay, remember what antidiuretic hormone means and what it does to the body. It's going to not allow diuresis. It's going to hold on to water in your blood. Okay, and you have a ton of this hormone now. So now your blood is completely diluted. So what are you going to want to rapidly tell the provider about when you look at these things? So a recent weight gain of 8 pounds. Do you think this person's going to gain weight when they're holding on to water? Yes. Okay. A urine specific gravity, 1.025. Okay. Do we expect that? So look up what a normal urine specific gravity is and check that. Okay. The patient complains of dyspnea with activity. Is that possible with this patient? Okay, so look into this disease in your textbook and kind of compare some of these. But what is going to be the scariest thing that we could find? What could easily cause a life-threatening situation? And that's hyponatremia. Okay, so whenever you have an electrolyte that's out of balance, as I've told you guys, we look for that very, very closely. We watch our sodium, potassium, chloride, magnesium levels, calcium levels at the hospital. If you have a serum sodium less than 120, you're at a highly increased risk for seizures, as well as cardiac problems and cardiac conduction issues. Okay, so you're teaching the patient about long-term management of this syndrome. Which of the following statements made by the patient needs correction by the nurse? So I should weigh myself daily and report sudden weight loss or gain. So if you're trying to do long-term management of this disease, then yes, of course you want this patient to be, weighing themselves and reporting any sudden gain or loss, right? So we're looking for again, what's that? What's the question asking is what needs correction? Which one is false? I need to limit my fluid intake to no more than 1 quart of liquid per day. So do you think that is a good one? Based on your reading and the education that you've given? Yes. Okay. I will eat foods high in potassium because the diuretics cause potassium loss. Do diuretics cause potassium loss? Yes, that's actually a huge problem from diuretics. Simple diuretics pull out potassium with the water. Finally, I need to shop for foods that are low in sodium and avoid adding salt. So as the rationale says, the blood is already diluted, right? The serum, they have hypoosmolality. And if you avoid salt, you're just going to worsen the situation, right? You're going to get a worsening hyponatremia. Okay? So I think those are the big ones that I wanted to go over with you. And let's see. Again, I really want you to look at Cushing's syndrome because that will be on your exam, and that's what your classmates in Patho are going over. So do look at Cushing's syndrome as well. And then finally, I wanted to go over just some things I want you to think about for the final exam. So your final exam is going to probably be between 50 and 60 questions. And it is cumulative. Okay. Some thoughts for you. You need to understand heart failure. You need to understand left versus right. You need to understand what kind of symptoms you're going to see with each and why. And then taking it further, you need to understand what nursing diagnoses are going to be the best fit for each disease process that you have. Okay? So if you have someone, for example, with left-sided heart failure, okay, you expect certain assessment findings, right? And from that, what's going to be the best nursing diagnosis for that patient? Taking it further, what kind of interventions are you going to do for that patient? So you're going to have to think about that for all of the major diseases that we've emphasized this semester. Excuse me. I'm going to ask you some questions, most likely on some of the different hormonal conditions and diseases. And what I expect you to know is, for example, with SIADH, what kinds of things are you going to see in terms of manifestations of that? So we kind of talked about that before, but, what's that going to look like in terms of urine? Okay. And then let's say the patient has diabetes insipidus. So they have insufficient antidiuretic hormone. What's that going to look like? How's their body going to manifest symptoms? And what's their urine going to look like? Right? And if we treat them successfully, how will those symptoms improve? How would they change? Okay. You're going to have to go back and take a look at ABGs, how to calculate ABGs. You need to know how to calculate the MAP, right? Some of the other basic calculations, you're going to want to know those. You're going to want to review tuberculosis and PPDs. You definitely want to be able to tell me what's the best diagnostic testing that we're going to do for the different diseases, including like tuberculosis, pneumonia, heart failure. So what are going to be the best tests that we're going to do that are going to give us the most answers? When you're talking about tuberculosis, remember that you need to know how to read a PPD. So if someone has an immunocompromised system, it's going to be different from someone who's normal, right? So you want to be able to know the difference and understand what means latent TB versus active TB, What does a positive PPD induration mean? Okay, so make sure you review all those things. You should understand the partial pressure of oxygen because we talked about that a lot, and also understand what a normal partial pressure of oxygen is. And we talked about a couple variations, but 80 to 100 is the one that I want you to go by, even though you may see variations in different classes and different textbooks, but the partial pressure of oxygen should be 80 to 100 normally in a normal person before you see any changes in the body. Now, clearly, if you see someone with a very severe disease that affects the oxygenation content of their blood, and you could definitely see a decrease in that, right? So kind of keep all those in mind. You should remember the SA node versus the AV node, and how many beats per minute, how many impulses should be given out depending on which node is being triggered. For example, if the SA node fails, how's the AV node going to compensate? You not only need to know about hyperthyroidism, but you also need to know about Graves' disease, okay, and worst case complications there. For hypothyroidism, again, you need to know Hashimoto's and basic symptoms and care for those patients. When you're talking about patients that have different diseases, whether they be respiratory or cardiac, depending on how their symptoms are, if they're having trouble breathing, you should know what position to put them in. Remember to review the orthopneic position. Remember that's sitting up and sitting forward and putting their head on an oversized little table with pillows on it. Okay, remember that that's going to decrease preload. That's not always the best position, but in certain diseases it is, so make sure you understand that. With patients that have trouble breathing, remember what position we're going to put them in. Go back to all those first diseases you learned about in upper respiratory. Remind yourself of influenza. Is that a bacteria or a virus? What about the flu vaccine? When can we give a live versus a dead virus to somebody? What were some of the other diseases you had? You had acute pharyngitis. Okay. Remember that acute pharyngitis can lead to acute bacterial pharyngitis can very quickly lead to another very serious disease that your peers presented on in patho. So make sure that you understand those and the repercussions of not treating that disease. You still need to know the basics of an EKG. You still need to know all that cardiac stuff you were just tested on. So you need to know what's going to be the scariest change in an EKG. You need to know what kinds of changes relate to myocardial ischemia versus myocardial necrosis. And you have a picture in one of your PowerPoints in textbooks that clearly defines which one is each. Remember to review PE as well as TB and pneumonia. Remember pleural effusions. Make sure that you understand all the big tests. So an echo versus an x-ray versus an EKG versus a stress test versus an angiogram. How are, sputum cultures taken? How are blood cultures taken? What do we tell the patient when we need sputum cultures? What do we tell them when we what do we do when we need to do the blood cultures? Why do we do those? What are we looking for? Remember to review asthma and to know what is the major medication I told you to know for that one in terms of a rescue med. Okay, so oxygen is great in a lot of situations, but when you're dealing with asthma, what's actually going to be the best medication for them? And we did talk about that. You should still be able to figure out a 6-second EKG strip and measure the heart rate, of course. You should know all of your isolation precautions for the major diseases that we talked about. So TB versus pneumonia versus some of the other ones that we kind of emphasized, okay? So what would you have to wear on your face for TB? What kind of room are they going to be in versus a patient with a classic pneumonia? There's certain medications that we've discussed generally, such as blood thinners, anticoagulants. We've talked about nitroglycerin. We've talked about some blood pressure medications. So anything that we spent time on to discuss or that I said was important for certain diseases, make sure you go back and you also review those. Don't forget about peripheral artery disease, okay? And what that means. So what kind of symptoms are you going to see if the peripheral arteries are insufficient, right? And remember that it's the same exact physiological process as the atherosclerosis that we see in the coronary arteries, right? That cause angina. It's just in the peripheral arteries. Okay. You also should know the difference between systolic and diastolic heart failure. You still need to know mitral stenosis versus like where you're going to hear mitral stenosis and what are you going to hear. And at what point during systole or diastole are you going to hear strange sounds. So you need to know those. How are you going to tell that someone's infection is getting worse? Is very important. What are some precautions if someone had a cardiac catheterization through the femoral, let's say through the femoral artery? So nursing care nursing care after a procedure like that and education beforehand, those kinds of things. You still should know some of the extraneous circumstances that are going to cause a patient's blood sugar to spike. Remember, we talked about a few things in the hospital that we do that can, or that patients come in with that make their blood sugar go high. We have to be aware of those things. Don't forget about my favorite disease, pericarditis, okay, and infective endocarditis. They're both fascinating, but they're very different. You should know, all the things that we emphasized, including the classic sounds you're going to hear, the classic symptoms. Be sure not to mix those two up. All right, you should know kind of what what's going to be worst case scenario with acute pericarditis if you don't fix the problem and the swelling continues? What are those follow-up situations that are going to happen, and how do we relieve them? Don't forget about classic hypertension. That's such a big one, but yet it's so important. You should know what types of modifiable risk factors and non-modifiable risk factors are involved with hypertension, as well as CAD. At what point does atherosclerosis become an MI? What's the difference between a peripheral venous problem and a peripheral artery problem? When are you going to have claudication? Remember, that was the symptom that my dad had, which is that, cramping, intermittent cramping in the legs. Do not mix up peripheral venous problems with peripheral artery problems, because they bring blood to different areas and they're going to cause different issues. Remember to review atrial fibrillation. That's probably the most common and most important arrhythmia that you would need to know at this point in time. And consider the difference between an atrial dysrhythmia versus a ventricular dysrhythmia. So which one is going to be more dangerous? Which one's going to be scarier for you? You should be able to figure out where a problem is depending on the levels of T3, T4, and the TSH. Okay, you should be able to figure out if the problem is in the thyroid or if the problem's in the pituitary. You still have to review hyper versus hypothyroidism and all the manifestations, all the nursing care for those as well. You definitely need to know the difference between type 1 and type 2 diabetes. Okay, they're two very different situations. You should know which one's going to be most likely to go to DKA and what is DKA. I think I told you already, but you need to figure out your, you still need to be able to calculate an ABG as well. Okay. And again, you've actually got your study guides by your case studies. So all that work that you've done all semester, all the reading that you did, all those highlights, all those modules, they're going to very easily prepare you for this final exam. So if you've been doing all that work already, I don't think you're going to have any issues at all. And yeah, so it's very exciting, but I think that we are about done. So good luck to you guys, and email me with any questions.